Hello, dear colleagues. How are you? Today is 16th of February, 2026. This is Republic of Kazakhstan, Almaty City, Presidential National Hospital. My name is Mynzhylky Berdikhojayev, and my assistant is Shayahmet Mahanbetkhan. Operating nurse is Mahit. The second nurse is Arzagul. Anesthesiology team, Juanch, and Жанна is anesthesiology nurse. Video support, Roman Povyshev. He's from Videon company. And now we starting the case number 2. The patient with the Petroclival meningioma, the diagnosis was clarified in 2025 in City Hospital in Almaty. The biopsy it was a transoval percutaneous biopsy of the tumor. And the histological variant is meningioma, yeah? Yes, it's a type 1 meningioma. And our colleagues recommended radiation, and radiation therapy was done. It's not a radiosurgery, it's not a gamma knife, just a radiotherapy. After radiotherapy, patient felt a couple of months of improvement. Yeah, the pain in the headache and the eye pain was released. And then it starts again. The size of the meningioma is the same. Рома, звук пока выключи, пожалуйста. Yes, the patient came with the same size of meningioma like in 2025. There is no improvement and there is no significant worsening, but the size of the meningioma is quite big. It's approximately, okay, let's check the angio. The some part is feeding from the right tentorial artery, and it's in the cavernous sinus and the intracavernous region. This is the meningioma, and this one is bigger. Okay, let's measure. It's approximately 5 centimeter, maybe a little bit less. Let's see. It comes from here till here, 4 centimeter, from here to here, and from here, something here. Yes, nearly 5 centimeter. And yes, we did angiography under local anesthesia. She's our colleague, that's why we discussed first the possible strategy. She has a pain, and that's why the indication for the treatment. And there is a supply from the ECA territory. This is a meningeal branch, middle meningeal branch coming to the tumor, but it's also may feed some facial nerve. Huh? It's a pyramid, it's a middle portion of the pyramid. And this is a tentorial branch. We did a 3D, it's clear. We will see. We took a headway septor mini. This is Fubuki angled, and then through the Fubuki angled we planning to place septor mini, and also the balloon hyperglide we will place in the ICA for the protection and the navigation. If any problem should happen, in parallel we can place headway 21 and deploy the P64 HPC if it would be needed. Patient is pre-medicated. We learned from last case, and yes, we learned to prepare the patient properly. And it might be some branches from the ophthalmic artery also, it's expected. Okay, the vertebral territory is clear. Yes, I'm not sure there is a pile supply. It all looks meningeal supply. Yes, and I hope there is no yes, there is no pile supply. It's very important. If there is a pile supply, it's a atypical meningioma, and if there is a only meningeal supply, then it's a type 1 meningioma. We did a 3D. Let's see, there is a meningeal trunk, meningotentorial or Bernasconi casinari. And the one branch is going down, one branch is going up. I think first of all we need to go here. It's also feeding the territory of ascending pharyngeal. Ascending pharyngeal also going there. Let's check it. Let's check it together. Yes. This is ascending pharyngeal. And ascending pharyngeal is, it's look like the both branches, occipital artery and ascending pharyngeal is arising from ICA, yeah? From this bulb, from here, not from the ECA, it's coming from the ICA. It might be this one. But I think it's this one. This one is coming here. We can try to go here. It's most safe. And then we can place a second catheter here. Unfortunately, it's a 7 French. Huh? Unfortunately, it's a 7 French. We should place septor mini, sonic, or we can go with sonic. We can occlude till here, and then we can go with sonic there. Okay, let's prepare the balloon. I need another one more Y connector. Very small. Okay, I don't need the Y connector. Y connector керек жоқ. Мынаны бүйтесің. Мынаны трехходовой маған бере сал. Мынаны Y connector ала сал. Шеш сал Y connector. Мынаны кигіз. Болды. Мынаны кигізе сал. Yes, Sheikh Ahmed is neurosurgeon. He is not interventional. Контраст и трехходовой краник. Yes, we will prepare both balloons. This is for flashing. Бақыт не болып жатыр?
Бүгін ғана шыққан ғой, аяғым.
Сен бетсе, онда басқа медсестраны жіберді, өзің мектепке барып кел. Бара жатыр ма? Егер керек болса, сөйте сал. Хорошо? Yes, it's an incident in the school, that's why I recommended Bachit to go to the school. We need one more трехходовой. We need one more stop hook for the scepter mini, and now we're preparing the balloon. Так, мынаның қайсысы енді? Шахмет. Бұның қайсысы Case-8. Yes, there is a little bit confusing because one of the wires is 10 and one of them is 8.
No, 8.
This looks like 10. Yeah. That's why it's very important when you take out the wire from the package. For one of them, it's better to put the torque to mark it. Экранды 15 сантиметр аяғына қарай тарта салсың Бақыт. Because Case-8 and the Expedition from the Hyperglide looks like similar, with the similar white Y connector, and it may cause confusion. Confuse. Okay, for the balloon we took 60% of contrast. For the Hyperglide balloon we took 60% contrast. Okay, let's check. Yes, balloon is okay. For the assistance in meningioma cases, I prefer to use Hyperglide than Eclipse, because Eclipse is compliant balloon and Hyperglide is more stable and more little bit stiffer than Eclipse. That's why if you inflate till 4 millimeter, it will be very stiff, and Eclipse is 6 millimeter. If you inflate till 4 millimeter, it will be still soft. Yes, and we took a 3-way stopcock. It's a recommendation from the company, from my Monero, and the same preparation like in other balloons. Just keep the tip of balloon up, and then start to inflate. Yes. The air is going out, and now the contrast will come. Contrast is 100% for Scepter Mini. Yes, now contrast came. Okay. And then we deflate the balloon. Okay. This is syringe from the squid, that's why it's a little bit resistant. It's better than the Menex syringes. Okay, it's not angled, that's why we can put it directly. Yes, I think we need to go to the ascending pharyngeal first, to take the territory from ascending pharyngeal, and in ICA we will place the balloon for assistance. Unfortunately, it's a 7 French guiding. Usually for Petroclival meningioma I'm taking 8 French guiding for the 3 instruments. Okay, no need. Okay, this is Scepter Mini. Yes, I hope Nurjan Sulimankulov is watching this video, the live stream. He asked for this patient because she is a relative. Okay. And this. Since October 2025 we have large focus used for the small focus defect, and I don't know how long we can work with this system. Maybe somebody from Philips will write the comment under the video. Okay. Бесман гепарин салсыз. Бесман гепарин и дексаметазон 12 мг. Yes, we will give heparin because of the balloon assistance, and the patient has a good collaterals. I hope it will be okay. Yes, now in the MCA territory and balloon in the ICA. Okay. We placed the balloon, and now I will take a little bit up my guiding catheter. The artery is coming from somewhere here. I had cases, we had cases have done from the middle meningeal territory, from the ascending pharyngeal, supplying transosseal the posterior fossa, and I think it's the case number 2 or 3 in my practice. It's not so frequent to see the nice ascending pharyngeal going to the tumor. Назад. Артериальный фаза. Назад. Вперед. Стоп. Okay. Родно. I hope we're at the orifice of occipital artery coming from the I see. This is one of the branches. There are two arteries, one going like this, and second бесми. It's all the time going to this branch, huh? A second. It's a small branch. The occipital artery, and we need to go to the occipital. Just a second. I think now we are in the occipital artery, and the branch is going here. Yes, I think the bone is in place. I'm not sure. There is a angulation. Okay, let's do angio from here. Yes, again, I need to close the syringe. There is a problem, huh? Just a second. I forgot to fill the rest of the balloon with contrast. Let's open it. Now it's better. We open this, and now we can take angiography. That's a tumor. Contrast detail. Okay, let's take this roadmap. As for a case like this, it's better to have something like hybrid 7, yes, because Chikai is a little bit stiffer, but then Chikai gives more stability. Смарт маска делала, да?
После. Или он прям.
Тоже будет. One more. It's also going to the tumor, huh?
Да, она
Yes, it's also going to the tumor. But it's better to go to the second branch. Take a little bit back. Sometimes it's helpful. I think the branch is coming a little bit earlier. Something here. It just looks like I think the branch is coming somewhere here. Yes, the branch is coming a little bit earlier. But it's already skull base, huh? Нервтерге қатысырақ деген. I think there is some branch. The bifurcation is something here. Okay, let's place it there. It's already in the supply of the tumor. There is no support, huh? There's no support. I think it's enough. I will give a little bit inflation. I don't see my balloon, but I think it's already there. Okay, let's now inflate it. Yes, now the balloon is inflated. Let's take out the wire. Okay, now we need a part from the brain side. This part. Okay. Line and this is contrast. Okay, let's see how it's look like. Stop. There is a small branch from the another pharyngeal, and the main trunk is coming from the upstairs. Huh? Okay. It's a vein, huh? It's a venous leakage. It's a venous component. Okay, let's check what was before. This was before. Yes, it was before. It's like a venous component. It's in the jugular territory. Okay, and let's see. Yes, I'm just scary from the rupture something. That's why. Okay. Now we will inflate the upper balloon. There is a little bit stenosis in the cavernous segment. It's very helpful to inflate the balloon. And now we can do angio, and from this point it might be the whole territory could be covered from the downstairs. It's look like this. You see? Yes, patient has a ACOM, and we already gave heparin to secure. Yes, I think we can inject from here. We can reach the Bernasconica scenario, and but it might be better to go directly. But then there is a risk if we will go directly. Yes, it's a plan B. It could be like this. We can go from here, but sometimes there is a little bit complex angulation. Okay, we can occlude from here. Balloon is properly occluded. Okay, that's occluded. That's ophthalmic artery supplying. Yes, we prepared patient premedicated with the ticagrelor. The lessons learned from the last time, and for the whole Petroclival meningiomas, we will start to give назад. Yes, there's another branch is coming here. Also, this is the meningeal artery, middle meningeal. No, it's not the middle meningeal. This is middle meningeal. It's also going to the territory. This is middle meningeal, but this territory is quite risky because of the possible neurological deficit. And this one is also a little bit supplying. Okay. Okay, we can check later. Я наружку наоборот. Оболочного, среднеоболочного. Возможно. Okay, we can penetrate the whole tumor from here. The vessel and the squid 12. Yes, I prefer to use the squid because of the better visibility. Обезболить, обездвижить, у нас болезненный этап. Yes, it's quite painful stage. Okay, let's check again. Yes, sometimes it's better to keep the balloon inflated with the longer. Yes, the ophthalmic artery is giving the meningeal supply. It's like this. And also we should keep in mind there is a branches coming from the right ICA. It could be connected the right and left. Райма? Екінші шприцке қалдығын жинай сал, на всякий случай. Анау жатыр шприц. We increase the radiation to the normal. It's not high dose. Now you can see there is a meningeal branch from the ophthalmic artery. It's also supplying the meningioma territory. It's also possible to use for the embolization, but it's better to go with the headway duo here, which is not on the shelf. There is another branch from the maxillary territory, and I think this is a middle meningeal, and this is another branch, and this branch could supply also the cranial nerves. That's why I'm not sure should we go there or not. This one, but it looks like it's possible to go. And okay. Okay, let's see. Okay, we put the septal mini in the ascending pharyngeal territory. Now we go from the collateral territory. Just a second, there is something downstairs. These all branches coming from collaterals. Yes, we have time. We're working from the ascending pharyngeal. That's why it's possible to wait, to think. And there is a million branches. Huh? Жаңағы тамыр қайсы екен? Okay, now we are going to the territory, and also there is another branches. It could be territory of the second ascending pharyngeal. Назад. Yes, it's some extracranial. Ровно. We should keep in mind there is a vein starts to the jugular vein. You never know which strategy is better. Now it starts to go to the venous side. Okay, it's a vein. The upper branch is still alive. If it's needed, we can go to the upper branch. Yes, downstairs is now more clear. The upstairs is not clear. Okay. There's some branches, small. Mynzhylky. It's in the bony structure. It's in the bony structures. It's a matrix. Huh? Okay, because of this vein filling, we should wait a little bit. The vein is filling. Let's not go to the upstairs. Okay, let's deflate the balloon for a couple of minutes, then we can inflate again. But now I will deflate. Okay. That's a regular deflation. Let's now get deflated. Let's do. Yes, the part in posterior fossa now avascular. In most of the territory. There is something comes from the middle meningeal, but middle meningeal also goes from the apex of the pyramid. Maybe we can go there, huh? Maybe. Let's see. Maybe better to go from the middle meningeal. We'll see. Rodno? Yes, we have a marker as a balloon. We shouldn't go to that territory, but now all contrast, all liquid embolic goes to the venous side. Huh? It's all in the vein. Huh? Okay, let's wait. Timer reversal. 1 minute. Yes, we couldn't place one more microcatheter. Let's analyze the middle meningeal territory. Maybe the next catheter we should go through this branch. This is middle meningeal. There is a bifurcation. One goes here, one goes there. Okay, let's take the global view. Again like this. This is branch. This small branch is. This territory is also supplies. Maybe we can go here, but there is tortuosity. It could be a little bit problematic. Huh? It's too small. Okay, we can go to the middle meningeal, check first middle meningeal, and then take decision. Yes, this branch. Focused on this branch. If it would be here, then we can inject something. Sonic touch. Let's leave it. I will take out my balloon. We can place it again, huh? Or should we go out with the Scepter Mini? We couldn't reach the territory, huh? Couldn't reach the territory. Traversa? Balloon up so report. Yes, it's still feeding. It's feeding from the upstairs. Назад, назад. Okay. Okay. The third instrument, I think it will not go. We can try, but usually could not go. Yeah, it was the question from one of the colleagues. It was a comment under the one of previous operations on the minute 38. You worked with pronation. Кисть. Только кистью как ты спираль закрутил где-то. I did a pronatio and continue the coiling. It's like when you use wire and navigate with the wire, the same principle. It's possible to push the coil like a wire. It's difference. My young colleagues, also the Maksat, is doing like this when he is navigating the wire and coil. But I'm doing it like this. That's why it was look like just a pronation, but it was a pushing the material. Бір видеолардың астына комментарий кейін оқып көрсең болады.
Почему вы так делаете?
Как вы могли так протолкнуть? It goes. It's instrument number 3. It was a Scepter Mini, Hyperglide, and now we're pushing the Sonic. Okay, now smart mask closer. Glue down, navigate. Okay, navigate. Smart mask. Yes, we will leave the Scepter Mini. We can use it later. Okay. Now the Sonic is arriving and the branch is here. It's too small, eh? It's too small. We should navigate Sonic here. Okay. It's a wedge position, huh? There is bifurcation. Then it's a little bit risky. If it's possible to push a little bit, then it's okay. If it's not, then it's also okay. Okay, let's do undo. And after that, we should be ready to place flow diverter stand because of the possible reflux and leakage of the liquid embolic. Yes, now we are in the wedge position. Okay, that's nice. There is no marathon. Maybe marathon of headway duo could be better for this purpose. Dem sudersan. Yes, I thought about the possible alternative. If there is any leakage around the balloon, also we can place a Leoplast tent, not the flow diverter. John Winners. Нам прицельствовали. Он нарым хресан. Из свежей глаз. Ну, свежий денес. Okay. Increase the radiation, more glue. And we continue to inject through the miniceptor, but at one period of time it continues to go to the vein. I will take it out. Let's deflate. It continues to go to the no problem. Yes. The miniceptor. Let's pull it out. Ну, хай там шприц открыть. Не, айнал дресом. Хорошо? Так. Тревис. Ну, берется. Okay, now we can focus on the territory of tentorial artery. And at this point I should inflate my balloon. Pardon? I think we should bring the balloon a little bit back because it's occluding. Yes, now it's better. Rodno. Так, non dinleysəş, aslında tasış. Okay, we have a proximal branch which could be the indicator of reflux. This is meningeal artery we saw before. It's a nice collaterals. It's already occluded. Yeah? Okay. Yes, we could use this meningeal. Huh? Okay. That's okay. Yes, this one. Now we realize that yeah, there is some tortuosity, but it was accessible one, no? With a less risk. And now it goes to the tumor territory. At one point, tumor may rupture. No problem. We occluded the... It's a rupture of the tumor. Okay. Предыдущий ангел, сэр. We should wait a little bit. Yes, in upper part, tumor ruptured. Usually it's asymptomatic, and in this case this part is supratentorial. That's why we don't scare it. There is a lot of normal brain, and it could take this pressure. I think it's a painful, and patient start moving. Обезболить, обездвижить, наркоз поглубже. Yeah, потому что пациент шевелится. It's very painful. It's a territory of trigeminal artery. That's why patient may feel. Yes, I think there is a tumor rupture, and there is also collateral branches. I don't know which one is, but it's look like the extracranial circulation. Yes, the some part is feeling from the ophthalmic, and there is proximal branches also alive. Yes, it's a branch from ophthalmic artery. Жоқ, ол бармайды. Мына астындағысы бармайды. Осылар, иә. Мынау. These two branches may supply the oculomotor nerves. Patient is moving. And there is no reflux, huh? There is no reflux. We still use the same territory, same branch, and there is a collateral open. Now it's a leak inside the tumor. Okay, let's analyze the previous angio. It's ruptured here, it's ruptured here, it's ruptured somewhere here, but it's okay, it's not a problem. We already occluded the tumor, and it's not so significant. This part is around the sphenoid ring, and this part is accessible for the resection, microsurgery, yes, if it's needed. But this is a matrix, and this artery is accessible for the embolization. Maybe it could be used as a second session if it's needed. If not, we can follow. Yes, that part is not so risky. It could be radiated, but the hypophysis is under risk of radiation injury. We'll see. We need to consult with the colleagues from Gamma Knife Center in Astana, and might be something left here, might be some branches still alive here. We didn't deflate the balloon, that's why I couldn't say is it okay or not. There is not so much pressure in the catheter. Now we are refluxing, and thanks to this second small branch we can see where the limit of reflux, and now we can feel the downstairs, and also we are ready for the stenting. It goes to the other territory. That's okay. balloon is stable. We use this concept. It goes to the right side, and now we should be very careful. We can feel the territory of tentorial artery from left to right. Okay, now we are around the balloon. We are ready for this scenario. Yes, we are ready for this scenario. We will place a flow diverter stand, or we can take a Leo Plus and we can place Leo Plus. The both is okay. Okay, we have time. Yes, René, Professor René Chapeau did a presentation about the AVM and when there is an en passant feeder. It's a risk of penetration of the territory. That's why when you deal with the AVM, you should be ready to stent retrieve. But stent retriever technique in this territory, it's not all the time effective and reliable. That's why we revised our strategy, and we will start to do stenting. And I hope it will be effective. Okay, I'm looking for the right side. This is the right side. This is not informative, this is informative. Yes, but maybe this is also informative. The artery small and then became bigger. If it's became bigger, there is an internal carotid artery. Yeah? Okay. The reason why we use the squid, it's very important. Squid is visible. Comparing with the other liquid embolics, squid is mostly visible. It's around the balloon. I think this is a limit of embolization. We can inject a little bit more, but I think we now reach the limit. Okay. We can bring 21 microcatheter. Headway general brush fish. Bach. Bach. Подожди, headway general brush. Или... подожди. Son бересенс. Фен керек жоқ. И не бересенші. Сөзде траксеспор. Той фен керек жоқ. Пока біз headway ашып жатқан. Вообще лево ашып тастай салуға да болады. Лево да болады.
Лево тастау. Неге лево?
Лево тоже плетенные, лево қысып қалады. Ячейкасы в принципе нормальная. Leo is okay, it's a braided stent and it might compress the squid, but I think the FD is better. Yeah?
Лево, по идее, қатып қалды ғой уже, да?
Okay, FD is better. Okay. We can use P64 or we can use Silk Vista. P64 дырша, наверное. Okay, let's use P64. Now we can navigate the microcatheter. Yes, we are ready for this scenario. It's a little bit expensive, but I hope the cranial nerves is alive, and now we need one flashing system more and one Y connector. И бір системаны жаңағы жалғай салыңыз. Yes, for clear understanding, now we have a squid outside around the balloon in the lumen of ICA. That's why. That's why, to prevent the embolic complication, the lesson learned from the previous experience, we're ready to place flow diverter stent. The last time we tried to do stent retriever technique, catch plus squidectomy, but it was not so effective, and some pieces of squid was in the MCA territory. As comparing with the squid technique, stent retriever technique, this is a little bit expensive, 5 times in Kazakhstan. Maybe in other countries it's even cheaper. In Turkey or in Georgia. Because of special regime and regulation. But in Kazakhstan it's a little bit costly. Huh? Okay. That's a 21 catheter. The sonic is already in place. Hyperglide in place, and now we are working with 21. We will place 21 distally, and then we can start to place as there is a risk of liquid embolic movement. Yes, I'm not deflating the balloon, and wire is Traxxas. Traxxas is very smooth, and it's better to go with Traxxas. Okay, you can go up with the guiding catheter. Okay. This headway is now downstairs. It has 2 wires, 2 markers. Okay. Now we're in the upper part. Okay. P64. Мақсат сұрап өтеді, P64 қай катетерден жүреді деп. Мақсат сұрап өтеді, P64 қай катетерден жүреді деп. Қаша көрінсе. Білімді жаңартып отырған дұрыс қой, бірақ бұл последний P64. Okay. Yes, P64 HPC, it's covered with the anti-thrombotic coverage. And now we will deliver it through the headway 21. It's a second generation. In Russia, The colleagues using 27 microcatheter because the first generation of the P64 was specially designed for the 27 iter. But fortunately in Kazakhstan we have the second generation, the newer one. And even this is after improvement. Delivery system is long and no need to take out the sheath. It was the problem with the first generation. Разрывной баллон introduced. No. Там где кояслас был. Okay. Almaydı. Şunlar sistemi yok. Okay. We have balloon in place, we have everything in place. Now we can check the brain. Brain is clear. I hope it's clear. Yes, it's clear. We'll start to deploy the stent for the aortic stent. Okay. It's arriving. There is a distal marker of the delivery system. It's a little bit problematic. I think we are in the AC territory now. Yes, it's AC territory. Ну-ка, назад, вперед. Okay. Can start to deploy. I will take back okay, now we are more safe because the inner wire is not so distal. I will keep pushing the stent and now let's start to open the IC. Можно мне говорить, автомобильные карты. Предыдущий ангел. Самый последний. Не, стоп. Родной классич предыдущий. Стоп. Roger. Navigate. Roger. Navigate. Navigate. Smart mask. Okay. We can start to deliver from here. I hope it will open, huh? Okay. The stent is partially opened. Okay. We should deflate the balloon. Okay, just a second. we need to inject a little bit more. Нені бересиш? Glue. Okay, I think it's enough. Enough is enough, huh? Yes, it's detached. It's detached. Not closer. We have a little bit problem because the stent is not open properly. Yes, maybe the silk could be better because silk is opening reliable, huh? Okay, I'll bring my balloon. I think it's stable, yes. We shouldn't rush, we have time, and everything is stabilized with the stent now. Okay. We'll bring the balloon down, and now we can inflate it again. Eh? We can keep it here for any emergency. Yes, to prevent the distal migration, we just inflated the balloon. Okay. Now opening the stent. Okay. We have balloon in place, and now we will do angioplasty. Balloon, the stent is not properly opened in the mid portion. I just took back the. Yes, now we are inside the stent. Now stent is start opening. You can inflate. Yes, then balloon is ruptured. That's okay, no problem. We can change the balloon. Okay, we should change the balloon. Обычный эклипс пересасываешь? Үлкен коробкадағы эклипс. Alt 15. Yeah. Жоқ, гибрид ол 12-14. Ол басқасы. Yes, there is a difference between the hybrid in Sonic and hybrid in Eclipse. In Eclipse it's 12-14, in Sonic is 8 or 7. Yes, patient already on ticagrelor in the вечером, да, или утром?
Вчера вечером.
Yes, in the evening Sheikh Ahmed gave loading dose and verified just no.
Verify çok güzel.
There is no testing. Okay, okay, no problem. We can test later. Because of the HPC, I hope it's also the security. But only problem, stent is not well opening because of the balloon inflated. Yes, in such a situation, the laser cut stent is better, but laser cut stent is not braided. The mesh is. Yes, I just placed the wire inside, and this is a regular single lumen Eclipse. We should just take back the wire, and this balloon is deflating. Okay. What time is it now? Okay. My flight in the evening, but in 1 hour I have a podcast with a well-known blogger in Kazakhstan, Asel Masheni. I don't know what about we will talk, but she is doing videos together with husband, and usually it's interesting. Eh? Так, микрокатетроидный, да, aslında. Yes, now the balloon is in place. We are doing angioplasty. Yes, we changed this strategy because I think not so many people is doing Petroclival meningioma embolization, and I think it's tips and tricks of dealing with such complex disease. It's algorithm. Huh? I'm inflating the stent. It's a stent plastic. Okay, let's check. It's preventing the distal emboli. Yes, stent is already in place. There is a remaining supply from the ophthalmic artery branches. Okay, we can take out the headway 17, headway 21. Okay, plus minus сколько? Okay, let's inflate the downstairs. The upstairs is okay. We should take the balloon a little bit back. At this point we can inflate once again. It's okay. It was the stenosis. If you noticed at the beginning of the case, there is a compression from the outside of the ICA because of the meningioma. And now we compressed also the detached tip of the sonic. Sonic is under the P64. Okay. Yes. Then it's clear. Huh? Then it should be clear. Okay. Let's take out a little bit. If it's needed at the second session, we can use the artery ophthalmic. Okay, let's check everything. I will ask Ahmed to send the patient for MR with contrast tomorrow as the first patient, and then we will share the images on NeuroDict and discussionary course. I'm not sure, is it possible to share the JPEG images on YouTube? Okay, the brain is clear. Okay, let's see. There is some spasm, no problem. After the deployment, we'll put the timer. I will ask Sheikh Ahmed after the control CT to do the second the last angio. It's a Kazakh thrombo test. There's the meningioma. The meningeal artery is nice. It's not more feeding the meningioma territory, and most of the meningioma is feeding now from the ophthalmic artery. Okay, it's accessible. If it's needed, we can go next time if it's needed. But I'm not sure we need. Yes, the remaining part may be this. Huh? Okay. The choroidal blush is here. The brain is here. The IC is okay. The IC territory is okay. Okay, let's see the. I hope we didn't injure the territory of. I'm not sure. Okay, let's check the oblique view. I'm not sure the stent is properly opposed on the proximal part. Okay. Let's do it in contrast. Let's analyze. Пока не... только скоро собственно. Let's look for the stent. The stent is properly open. Here is okay. Here is some... it's fully opened and fully opposed. Fully opened and fully opposed. We can measure the ICA diameter before and after, and I think it's nearly similar. We can measure this one. Let's see how much we could open the 1.8 it was before, and at the end of the case Yes, it's look like the compression from outside, and now the artery is 2.5. The white line is a sonic, tip of the sonic. Okay, let's do first expert CT, and at the minute 15 we will do control angio. After expert CT we can finish the streaming. Okay, and Sheikh Met will do angio on minute 15. I hope it will be okay, and hope to see you at 2:30, 3 p.m. Almaty time, Astana time, which will be in 2.5 hours. Now I need to go to the podcast, and we have intracranial stenosis cases, vertebral artery stenosis, and a couple of aneurysm cases. Let's see. Okay, let's see. Қазір, күті жасайсың. Кітін ортаға шығарасыз, Sheikh Met. Okay, dear colleagues, CT is ready. Now Sheikh Met will do the full screen image. Okay, let's see the brain. This, I'm not sure what's this, but it's look like something in the cortex. The brain is clear. This is meningioma. It's quite big, and we reached all this territory and also here. The some part is remaining here. We'll see on MR, but now you can see the most of the meningioma now occluded. This is the intracavernous part, which also have been reached. We'll keep the patient in the department, and I will ask also the Sheikh Met to do angiography. Now we can go to the right side, do angiography from right to check it, and then okay, Sheikh Met will do angio from right, then go back to the left. It will be minute 15. And then if everything is okay, he will show the thumbs up. Okay? Okay. Now I will disconnect the audio streaming, and Sheikh Met will continue the video stream, and in next 10 minutes I hope we can finish. And this one in meningeal territory. It's not this is meningeal artery. Okay, let's check the last angio. Check this one. And now we can check this one. There is nothing. Even there is something, it's a meningeal territory. The brain is clear. Okay. Okay, thank you for watching. Please continue watching for another 10 minutes and see you in 2.5, 3 hours. Have a nice day.